For the most part, everything's all the same shit.
And then in terms of like microphone and like sound, that's all.
Yeah, everything's all involved. If you want to just, it might be smart just go ahead and push this.
Yeah, that sounds great.
Yeah, like you do.
That's one of the things we talked about. That's a big part of the speech.
Another plug as well.
Hey, Mike.
Right? Exactly.
So basically, just check this out a little bit, make sure the icons are running, make sure the shot makes sense, as well as making sure it's on. If you need to, you can zoom in and out, get the committees and second goes on.
Okay.
All right, text me if you have any
All
need.
right. Well, thanks, Cameron.
Yes.
I enjoy it. Thanks for coming.
Meeting of legislative health order. We're going to do a quick executive session. First bill up is Senate May substitute for Senate Bill 342, carry the bill and it's into the law. We handed out this version last week, so everyone had a chance to look at it. I didn't want to exact because there were a lot of changes, but something that the document committee are okay with, maybe not real happy, and most of yours are pretty good. So entertain a motion to adopt the committee substitute. Second. Any discussion on committee substitute? Anybody read it over and have any major heartburn? Seeing none, those in favor of Senate Committee Substitute Senate Bill 342, signify by saying aye. Aye. Those opposed, nay. Now, entertain a motion to move out Senate Committee Substitute 342 out of committee to pass. So. Second. Any discussion? Madam Secretary, roll call.
Senator Brown.
Aye.
Senator Shaw.
Aye.
Senator Cunningham. Senator Onder. Senator Stater.
Aye.
Senator Schmidt. Senator Silvey.
Aye.
Senator Chappelle-Vidal. Senator Shute. Senator Simpson.
We'll leave this one open till 1 o'clock or so. Let's see. Next up is Senate Bill 431, Senator Onder, presented that I think last week, maybe the week before. And there are no committee substitutes. The bill is presented. So I entertain a motion to vote Senate Bill 431 out of committee to pass. Here's that. Second. Any further discussion on 431? This has to do with the 39K audit and compliance unit, and it looks like it makes sense, kind of common sense, and make a few changes there that might be more important towards interpretation or application of what goes on with their health. Seeing no further discussion, Madam Secretary, please call the roll.
Senator Brown.
Aye.
Senator Shaw.
Aye.
Senator Cunningham.
Aye.
Senator Onder. Senator Sager. Senator Schmidt.
I'm passing my right now.
Senator Silvey.
Aye.
Senator Chappelle. Senator Singh. Hey. Senator Simpson. 5-1.
Thank you. Okay, next up is Senate Bill 496. Senator Hegeman presented that bill last week, the palliative care. And, we had a lot of talk said, why do we need this? And I think some folks just don't have a level of understanding. I think this is a good starting point, honestly. I kind of like this bill. I would like to throw it out, at least get it for discussion. And there are no committee substitutes, so entertain motion to vote Senate Bill 496 out for the committee. So here a second.
Second.
Yeah, a second. Any discussion? I think this is a good start. Madam Secretary, roll call.
Senator Brown.
Aye.
Senator Shaw. Senator Cunningham.
Aye.
Senator Onder. Senator Sager.
Aye.
Senator Schmidt.
Aye.
Senator Silvey.
Aye.
Senator Chappelle. Senator Shute. Senator Simpson.
7-0. And with that, we're out of executive session. Madam Secretary, call roll.
Senator Brown.
Here.
Senator Shaw.
I'm here.
Senator Cunningham.
Here.
Senator Onder. Senator Sager. Senator Schmidt.
Here.
Senator Silvey. Senator Chappelle. Senator Shute. Here. And Senator Simpson. We have a quorum.
As a quorum, we're going to hear 419 today. And Senator Silvey, if you're ready, sir, go right ahead.
Thank you, Mr. Chairman, members of the committee. Senator Silvey, District 17, presents Bill 419. This is the first, what I would consider true Medicaid transformation reform bill that we've heard as it relates to the coverage gap. As you know, I voted with most of you on this panel against taking Obamacare Medicaid expansion and just doing it as it was imagined in the ACA. However, as we look around the country and we see a number of Republican states, governors have negotiated deals with CMS that have allowed them to transform their system in ways that I think would be beneficial to the state of Missouri. I think that we ought to move in that direction as well with a state-focused solution. Basically, what we're talking about is the current Medicaid eligibility for childless adults in the state of Missouri is 19% poverty level. We hear all the time the numbers in percentages, 19%, 138%, but I don't know how many of us actually really internalize what that means. 19% for an individual is $2,236. So basically, we have a system right now that is covering the people who probably don't have jobs, people who aren't trying to climb that economic ladder and get out. But what we're not covering are the people who are trying to get out of poverty, the ones who are working, but are not necessarily in a position to cover themselves. 138% poverty for a single person is $16,242. So thanks to Obamacare, we have a system that if you make $16,243, you're going to get federal subsidies for your health care. If you make $16,000 even, you get nothing. You have no health care coverage. If you don't have a job and you make $2,100 somehow over the course of the year, you're going to get covered by Medicaid research. So we're basically paying for all the people who are working today. We're not giving anyone a hand up. So this coverage gap is a problem. The other thing that it does is it creates a huge uncompensated care problem, because when Obamacare was passed, the original bill imagined that all states would be mandated to expand Medicaid to cover this population. In order to pay for that, they cut disproportionate share payments to hospitals. When the Supreme Court gave us the ability to decide whether or not we wanted to expand or not, they didn't change the funding mechanism. So the dish cuts are going to go forward, but we are not going to have any way to offset that in our healthcare system here in the state of Missouri unless we figure something out. And that's going to lead to, I mean, we're already seeing, particularly in rural Missouri, having health problems. The rural health centers are having trouble recruiting and retaining talent because we simply can't compete with the other states around us. We're losing doctors to Arkansas, Iowa, Illinois. We're going to see more of those places continue to close or contract, which is not good for any of our constituents in outstate Missouri. You know, when I first got involved with this issue, when it first came down, of course, I was still on the House side as chairman of the Budget Committee, and my main concern was we can't afford it. It's unsustainable. We can't afford it. And I think that's true when you talk about just taking the expansion as it was given to us in the Obamacare law. I think that if we do that without any budget protections, it would be a terrible course for the state, and that's why I voted against it time and again. However, I think there are ways that we can offset that and protect our state against those unsustainable growth numbers. And I've actually been provided with two things. You've got a Senate committee substitute to consider, but then you also have a spreadsheet. In the spreadsheet are numbers compiled that show how all the costs would lay out. And you see Section A is the number of newly eligible participants in all those fiscal years projected out. Section B is the cost for those newly eligible participants. Section C is GR savings by cost shifts in the current program. And Section D is the general revenue increases that would be needed. And then finally, the summary at the bottom. What Senate Bill 419 pretends to do is create a trust fund that would capture the cost savings from the GR shifts that would occur with the newly eligibles. It then sets that money aside and then says that's the money that we will use in future years. So it's completely money that we would be spending on the current Medicaid population if we don't do anything at all. We capture in a trust fund, we use that to protect us against future increases by providing the expansive coverage. That's one concept. The spreadsheet clearly shows that is a sustainable projection, that we would be able to do that for many, many years. That's something that no other state has done. When you look at the states that have run into cost overrun problems, none of them have put any sort of future-looking cost protections into their plans. To me, that was the most important thing to come up with before we talk about any other aspect of this problem. However, the second thing you have there is the committee substitute, which would allow us to consider looking at something similar to what Tennessee has done. Tennessee, in their proposal, actually went straight to the providers and made them pay the cost of the new eligibles. In essence, not costing the state a dime, but making the healthcare sector pay for it from the beginning all the way through. The interesting thing about that proposal, if we were to consider it, if you look at the summary on Section E of that spreadsheet, if you look at number 5, that's the total savings from the trust fund. And it shows how many millions of dollars every fiscal year, starting with 80 million, then 153, then 187, 186, 134. Kind of projects out. If we were to go with the committee substitute and have the providers pay for the state's match, starting from the very beginning, you could take line 5 and add line 1, because we would not be paying GR costs to new eligibles. We would have the healthcare sector paying for that. So, for instance, in fiscal year 17, we would realize 153 million in savings, plus we wouldn't be paying the GR costs of the new eligibles. So that's another 40 million. 723. So essentially, in fiscal year 17, it would free up $200 million in general revenue. Now, the reason that I've provided the second proposal there, obviously, one, it protects the state against cost, but two, it actually provides us with revenue to look at the MODOT problem, to look at the health or the education problem, which are formulas that's still underfunded. It actually would give us an opportunity to address some of these other problems while protecting the state at the same time by making sure that we're not the ones paying the match down front. The way that we look at what we would actually do with this community in 419 and how we would handle the eligibles in 419 is a block grant proposal. Now, whether it's a block grant or a global waiver, probably need to be semantically worked out with CMS, because they've given a global waiver to the state of Rhode Island, so we know that that's a possibility. But the idea being, look, we have the opportunity here to completely rewrite the entire Medicaid program. That's something that we can't do today. If we want to add workforce participation requirements, we can't do that without getting a specific waiver from CMS. If we want to add co-pays for non-emergency use of emergency rooms, we can't do that today without a waiver from CMS. So what I'm proposing is we basically tell the federal government, okay, you want us to take this money and try to cover this population. We will do that on the condition that you allow us to completely rewrite our program to fit the state of Missouri as we see fit, and let us start from scratch. And when Senator Lansing suggested this to me on the floor last year, my initial reaction was, I'm not a fan of that because I don't want to give the governor wholesale ability to completely rewrite the program with this department. But what I've done in this bill is said, okay, let's do a joint committee of the legislature. I think it's 5 members to the House, 5 members to the Senate, and let us rewrite it. And then we participate, we cover the problems that have been mentioned, we provide a hand up to people who are actually trying to better the lives of themselves and their families. We rewrite the program to do actual reforms, not just pick around the edges like we do right now, but actual concrete reforms that would make the system both better and more sustainable for our state. We covered the problem with losing talent to other states, cut off the further contraction of rural health closures and closings that we're having around the state, and all while being able to protect our state budget. So that is the proposal in 419. Again, with the committee substitute, you have 2 different ways to go about it. Either with the trust fund, which realizes a little bit lower savings, but it does ensure that we won't spend more on this new population, or going straight to the providers and making them pay for day one and creating essentially a revenue stream that doesn't exist today in general revenue. So with that, I know there's a number of people that want to testify on both sides of this, and I'd be happy to answer questions.
Question, please. Senator John.
Do you know how much the hospital industry are receiving as a result of the tax credits that have been granted now for the last 15 months through the exchange?
I'm sure that someone from the hospital would be able to answer that question.
My understanding was that Tony, or at least up front, it was said to be about $1 billion coming into Missouri from the exchange. And all of those people theoretically, prior to getting insured, were the uninsured. And that's what the DISH payments were supposed to be. DISH provided about 40% of the funding. So now all of those people who were theoretically just an absolute 100% cost to the hospitals, now they're getting paid even more than their cost because they're covered under an insurance plan. So one way to calculate that would be, usually hospitals get about 40% of the premium dollar. So if it's $1 million, they should be getting about 400 million more. That should offset any addition. I just thought, see if you had a comment on that.
Well, not being the CFO of the hospital,
Maybe.
I don't really have a comment on that. Maybe someone else would have a better perspective on it.
The other thing is I've always been told that the federal government has a rule that if you go the block grant route, that you're forever locked in to that amount of funding. But
I think you can. I think the way that Rhode Island did it, and I know that there's someone here that can probably testify to that better. But I think there's a cap It kind of sets an escalating cap.
An escalated cap. I was told that, well, because we discussed this years ago when we were looking at insurance Missouri. And the department was very adamant that they didn't want to go block grant because the cost of healthcare go up, but the funding from the federal government stays the same, so then you just get tighter and tighter and tighter. I don't know, but maybe we can find out the answer to that.
Well, I certainly know that block grant is not something that's universally accepted. I know there are a lot of people in this room today behind me that are probably not super excited about the idea of you and I completely rewriting Medicaid from Ward 1.
Anyway, thank you.
Senator Onder. Yes, Senator. I'm sorry, you used the phrase cost savings from general revenue eligibles.
Right.
So are you saying that there are folks currently eligible for our current remote health net program that will instead be covered by this Obamacare expansion?
By running down the new funds.
Yeah, so they're currently eligible, under the 64 program. How are they eligible for?
I think the budget director would probably be able to answer some questions, but I think Sean's going to testify that. These are the numbers provided by DSS.
Because you use the word, savings, and I think, and you said that we have up to $200 million in your revenue, based on your bill.
Savings.
Savings is right word. How do you reconcile that with the fact that many other expansion states have had cost overruns rather than savings?
Very simply, the other states didn't put the budget protections in that created.
Okay, and I apologize.
And in fact, having the opportunity to look at other states and see what's failed has given us an advantage in being able to protect against any problems.
Sure. Oh, and can you tell me a little bit about what the global waiver that Rhode Island got? They didn't do, no state has done a block grant approach before. What was Rhode Island doing exactly?
So again, block grant global waiver is a little bit of a semantic diversity. Basically, what we're talking about is the concept of the federal government saying, here's the money for you to spend. You figure out how to best cover the population that we expect to cover. Rhode Island was given a global waiver. It was the last waiver given by the Bush administration. And they basically, and I think there's someone here to testify more to the specifics of Rhode Island in particular, but they were basically given the freedom within their Medicaid proposal to use that money as they see fit, to put whatever reforms in they wanted. I know they did some changes to in-home nursing homes, some of the others, as long as their population is covered. They came up with a formula of how many people should be, it was kind of like a Mark Foundation formula for students, right? So they came up with a formula of how many people you should project each year, give them a per person stipend, send it to the state, let the state figure it out.
And that was, of course, that was pre-ACA, it was administration. So did Rhode Island, they are a Medicaid expansion state under the ACA, correct?
I don't know if that,
Yeah,
there's 29 of them.
I believe they are. I'd be curious too what Rhode Island did under their new flexibility. That global waiver was given to Rhode Island under the Bush administration.
It was the last one approved by the Bush administration.
Do we have an indication that an administration that wants to approve a $10 ER copay will approve a block grant or a global waiver similar to the Bush administration?
You know, the way I look at it is, if I had my way, I would get the federal government to tell us no.
Your idea is they're maybe desperate to get more Obamacare expansion states, and they might be willing to go for the deal.
Well, my idea is that they say that they want all these people covered, and if we have a solution, I dare them to tell us no.
And of course, your plan would increase eligibility up to 138% operating especially ACA.
Correct, which is $16,000 a year for an individual, $22,000 for a family of two, just under $28,000 for a family of three, and $33,000 for a family of 4.
Are you familiar in some of the ACA expansion states when the budget, when their equivalent DSS budget gets tight, then they have to go back to the previously eligibles, the 60-40 or in many states 50-50 population, and cut some of their kids, the population, cut some of those benefits in order to make up for the cost overruns that occur in the expansion.
I would just say it's unfortunate those states didn't have the foresight to put in budget protections like I have.
Thank you, Senator.
On your GR savings on your budget,
Yes.
number 5, ETD, what is that?
I would ask Linda if she's here to answer that question. The department's the one who compiled this.
All right. Any other questions? Senator?
Excuse me. You mentioned providers picking up a lot of this cost. Would they get that?
In the committee substitute, that's what it would do. It would make the providers pick up the cost of the state share of the new eligibles.
Where do they get that money? By raising rates to people that do have coverage, or where are they going?
No, I mean,
they claim they don't have funds now.
Well, no, I look at it like this. I mean, if you take the, if we expand to cover these people and we get the 90-10 match, basically, that's going to be about $2 billion that flows through the state. So instead of $2 billion flowing through to them, it'll be about 1.8. So they don't raise necessarily the rates on anybody. Essentially, they have a huge pot of uncompensated care right now, and they have zero ability to deal with it, at least in this simplistic formula. So rather than giving them $2 billion, we just give them 1.8 and let them figure it out.
How would you wean off people as they approach the $34,000 deadline? How do you wean them off to give, you know, suddenly if you make $35,000, you're going to be stuck with $10,000 worth of insurance.
Right.
So
Well,
how do you wean those people off?
Well, that's what's crazy about Obamacare, because there is no weaning off, because if you make $35,000, you're on subsidy for the federal government today. Feds give you subsidy to go into the exchange. So there is no cliff. What we have right now is if you make $35,000, you get a subsidy to go in the exchange. If you make $33,000, you're on your own. And if you have no job, we're already paying for you. That's what we have today. So you don't have to worry about the cliff, because they're inexplicably already paying for people who make more money.
But would it be some people not want to better themselves by making more money because it's going to cost them?
No,
They
because
suddenly have to participate and pay part of it themselves, even though they're getting a subsidy?
No, because they'll get the subsidy to go into the exchange.
Next question. Doctors, I have a shortage of doctors. Suddenly we've got more people who need more doctors. Where are we going to get these doctors?
Well, the problem is today we're actually losing doctors to adjoining states because they are able to pay their doctors more because they're drawing in federal funds to do so. So I think that we would have the ability to attract more doctors if we had the money to offset the uncompensated care.
In my area, I'm not losing doctors, but I can't get doctors.
Right. That's because they have a bunch of uncompensated care they have to figure out how to balance on their books. If all of a sudden that was taken care of, they could pay their doctors more.
Thank you.
Any other questions? Senator Silvey.
Thank you, Chairman. I do always like the one part. And this is just for childless adults with ages of 1964, is that correct?
Well, that's the expansion community, but what I propose is that we tell the feds that we will cover that community, but we want to block grant for the entire program, which is why there are probably several people behind me that are not in favor of this. Because I would give us the ability to rewrite the entire program.
Okay. So you should include pregnant females.
I would include everyone that's covered today, plus the new eligibles, to give us the ability to rewrite it.
The healthcare services tax. Sounds like it's not like an FRA tax.
In the committee substitute, yes, it's a tax that would mirror the FRA. It's actually very similar language as far as how it's adjusted every year. So that's the concept, yes.
Okay.
It would be like an additional FRA specifically targeted at paying for this match.
And was the idea to kind of mirror the amount of the FRA tax?
No, the idea is to mirror the cost of the federal match. So you know, when Tennessee came up with their proposal and said the state's not gonna pay for this, we're gonna make the providers pay for it, they had room in their actual FRA to adjust the FRA rates and raise the money that way. We are leveraged to help on FRA.
That's right.
Right, so that's why this committee substitute creates basically a new smaller FRA that would be specifically for payments matches.
Now, we be able to draw down federal funds using this tax.
I don't-
Or is that?
No, it's just a pay match.
Okay.
I mean, we would be drawing down the federal funds by virtue of having the money to pay the match. If that makes sense.
I do have a little consternation of the tax of some of the entities you have listed here that probably are not getting compensated here for additional things, you know. I know hospitals would benefit, but I'm not so sure about ground ambulance and some of the others.
Well, Senator, I just wrote it to mirror the FRA. If the committee would like to do it in any way, I'm open. My concept is, I think that we could go down a path where they pay for it instead of the taxpayers. And that would allow us to take advantage and solve some of the problems. If we want to tweak how we go about doing that, I'm completely open to it. It was just throwing out the concept.
Senator Shaw. A follow-up. In your bill, you are going to cover a new category of eligible recipients that shall include individuals aged 19 to 64. And then there's these key words, says who are not otherwise eligible for mental health services under Chapter 208. So there are people who are disabled that are on spend down, just between 85 and 100% of the federal poverty level. And you booked seats for those people because when you move them from the current coverage over to this category.
Right.
How do you get around that language who are not otherwise eligible under the current program?
Well, my understanding is that that language is there because they're already on, but we can still do the cost share. And if I'm wrong in that, then perhaps someone else in the department can clarify. So.
Seeing no other questions, normally what we do is, I'm sorry, Senator.
Thank you, sir. Thank you, sir. So, this plan will be based on sort of the existing framework of Obamacare ACA. If the Supreme Court rules subsidies are no longer viable today, that obviously is a game changer for this model. Because you're essentially basing it on people being able to participate at the level assumed with the subsidies. It's not necessarily a system, it's just a reality that if that case gets ruled against Obamacare, it changes this chart.
My understanding is that it doesn't, because the King Burwell case is talking about those that are over 138% that are getting federal subsidy to enter the actual insurance exchange. The Medicaid isn't even up for debate in the King Burwell case, is my understanding. So we're talking about is the federal match. If I use the word subsidy, interchange.
Okay, no, that's the name for my question.
King Burwell is above 138, they're getting private insurance through the exchange.
Okay, thanks.
Any other questions? Seeing none, normally what we do is, someone for, someone against. We don't normally do, information only in this committee, but today since, budget director agrees either, she would probably rather testify for information purposes only. So let's have her come forward.
Good morning, Mr. Chairman of the committee. I'm here to provide information on the proposal on Medicaid expansion. I am going to focus just on the savings piece. So I will start there, and I will be working on the chart that you have. Jennifer Tidball is here at the back of the room. If you have more detailed questions, you may need to call her up. So let me focus on that area. It's box C. So if you're looking at the long sheet, box C. And there are really savings to existing state services. So we're talking about services that the state of Missouri already provides and generating savings from those services. There are broadly 3 categories. I'll walk you through those very briefly. So the first category is really probably the easiest to understand. It is individuals who are currently being provided services with 100% general revenue. So no Medicaid match, these are not Medicaid eligible services. And those are represented on rows 7, 8, and 9 on the sheet. So rows 7, 8, and 9. The biggest category there is obviously row 9, Department of Mental Health. The Department of Mental Health currently serves individuals who do not qualify for Medicaid because they are over the Medicaid eligibility limit. They provide those services with 100% state general revenue. The day that we are given approval to expand Medicaid in this state, we can immediately move those services to being matched by the federal government because they will become Medicaid eligible services for Medicaid eligible clients. Those are people we know, they're people we have in our service, immediately movable to federal funding rather than general revenue. And that's an estimated 37,000 individuals. Row 7, a much smaller change, obviously, if you look at the dollar amount on row 7, that's the blind pension Medicaid program. We currently serve individuals who are blind or visually impaired using 100% state funds. Very few of those individuals, about 75, would qualify for expanded Medicaid, and we could immediately move them over to being paid, those same services being paid with federal dollars rather than 100% GR. The final one in that category is Department of Corrections on row 8. We have a very limited ability in Department of Corrections to claim Medicaid for inmates, and that is out in inpatient care. So if an inmate goes to a hospital, has an overnight stay, Medicaid will cover those costs. That's true today. That isn't being changed by Medicaid expansion. What is being changed is we will actually have inmates who now qualify for Medicaid. They don't currently qualify, they would qualify. So those services would be shifted to federal funds. The next broad category of savings is for individuals who are in the current Medicaid program who in the future, when those same like-type individuals come in and apply, they would go into Medicaid expansion rather than regular Medicaid. That is a key difference. We're not talking about shifting people who are currently in the Medicaid program over because we cannot do that. We're talking about individuals who will, as they come in the door new, will come in and apply and come in through the Medicaid expansion route rather than regular Medicaid. Those individuals are reflected in rows 1 through 6 on your sheet. I will mention them very briefly. They all basically work the same type of way. So row 1, pregnant women. Right now, the state of Missouri offers Medicaid services to pregnant women up to 185% of the federal poverty level. In the future, if a woman comes in before she is pregnant, so this is somebody coming in before she is pregnant, not when she is pregnant, they will go into the Medicaid expansion bucket. If an individual waits until she is pregnant and comes in and applies, we will still pay for her costs using regular federal match. That was a question that Senator Schock asked. So if that individual is eligible for regular Medicaid when she shows up at our door because she's waited until she's pregnant to come in, she will stay on regular federal match, not expansion match. So it works basically the same way for these other categories: breast and cervical cancer, ticket to work, spin down. Row 5, permanently and totally disabled individuals, that's the disabled community. And then row 6, women's health services. I'll briefly mention spin down. The way it would work, those individuals wouldn't be eligible for Medicaid, regular Medicaid in the future, because they would not have spin down. They will no longer have to spin down. They'll come in through the Medicaid expansion bucket. They haven't met spin down, so they're not eligible for regular Medicaid, to your question, Senator Shaw. So they would come in through Medicaid expansion rather than regular Medicaid. The permanently and totally disabled population, these are individuals who the state of Missouri serves who come in through the disability door right now, but never qualify for SSI. So they come in and apply for Medicaid and come in through the SSI route, but a certain group of them never qualify for disability. There's no reason for those individuals to put themselves through the pain of trying to qualify for disability if they can get health care coverage through Medicaid expansion instead. So instead of serving those people with 37% GR, we will be serving them under Medicaid expansion at a maximum of 10% state funds. So those are those categories. Finally, I mentioned the third bucket. You see on row 13, a savings for reduced recidivism. Those are people on probation and parole who currently we are not able to provide services for them because they're too expensive, because it would be 100% general revenue. So we simply don't have enough 100% general revenue to provide mental health services to individuals who are on probation and parole, at least not all of them. Department of Corrections has proof that providing mental health services reduces recidivism. They actually see that in their statistics. So they provided this information to us. If we can afford to provide more mental health services, we will have lower recidivism rates, fewer people going back to prison. So those are the broad three categories. And finally, just to briefly mention, there have been studies on states that have expanded that have confirmed these savings. So the most recent one, Deloitte, did a study for the state of Kentucky and discovered, yes, indeed, the state of Kentucky saw these savings. The difference is, as Senator Silvey pointed out earlier, the state of Kentucky did not set those savings aside. So they saw the savings, but they didn't put them aside in the trust fund. With that, I'm happy to answer your question.
Thank you. Senator Chu.
I got you.
Okay. Senator Shaw.
So, all of the people that are currently disabled right now would have to stay on the current spend down.
That's correct. If they're not, anybody who's currently in Medicaid, the federal law is written that we have to continue to provide those services under the existing Medicaid metric. Now, the little bit of difference that you just mentioned there are spin down clients. For spin down clients, they have a regular process. So no, those individuals, if they don't meet spin down, will suddenly become eligible for Medicaid expansion. So they are unique in that their eligibility is determined every month based on spend down. And if they're not spending down, then they're no longer eligible for regular Medicaid and they can come through the store instead.
So is there a time period of when they would have to come in or not meet their spend down? I mean, do they have to like not meet it for a month or 2 months?
Each one of them might be different. I don't know if Jennifer can explain a little bit more how spend down works. I don't know if it varies by individual.
Jennifer Tidball, Department of Social Services. Senator, spin down, really the way it works is if someone walks to the door, they're eligible resource-wise, they're eligible asset-wise, but for they have too much income. So basically, the Family Support Division makes them eligible that says to be eligible to receive Medicaid benefits, you're going to have to spend down a portion of your income. And that's looked at on a monthly basis. So we did ask for guidance from some legal guidance around, we asked the same question you did, Senator, whether or not these individuals that perhaps 1 month they meet their spend down, 1 month they don't, but they've already kind of walked through our door and we said you are spend down eligible. We asked the legal question whether or not if they didn't pay their spend down a particular month, whether that be 200, whether that be 1,000, whatever that difference might be between what income they could be on full Medicaid, the 85%, and what they're making. would they be eligible for the expansion? We were told because, like Linda said, because spin down is a monthly eligibility look. If I'm an individual, I walk through the family support door, I've been told as a disabled person that, and I can't be on Social Security, so I can't be a dual. I can't be Medicare. So we're only talking about the people who are non-Medicare and are on spin down. So I'm disabled. If I'm told your spin down's $1,000, I might pay it. I'm just going to make this up, January and February, but let's say expansion would happen in March, I wouldn't pay it. And if I otherwise qualified for in that expansion population, then I would be on the expansion.
So do you have that in writing from CMS?
I don't have it from CMS, but we do have something in writing from some legal staff that we retain from Washington that has a connection with CMS.
And is this how it's working in other states? People, do they even have spin down?
Some other states have spin down. Not all states have spin down, but some other states have.
And
my knowledge
provide us some documentation as to how it works. So basically, what you're going to do is you're going to move every single person that's on spin downs over to
no, they're not every single.
only every single person who's disabled under the age of 65, who's not otherwise on,
which we have of our total population spin down who pays in, which is about 19,000. I think we're estimating on our sheet about 280, 275 would fall under that definition of being able to qualify through the expansion. So the majority of those who are on spin down wouldn't qualify for the expansion because they're dually eligible. So the expansion doesn't allow for individuals to be covered if they're on Medicare.
Because they're on Medicare,
yes.
Because they are disabled and they've gotten SSI benefits,
yes.
So they're on Medicare.
Or they're eligible.
So you're only talking about, what's the size of the population that are dual eligible?
We've got on spin down, we estimate that over 19,000 are in the program and that 2,700 would move.
So you're still going to leave most of the people who are disabled are still going to have to live at 85% of the poverty level, basically.
Based on the fact that the expansion language doesn't allow for us to cover individuals who are also on Medicare or over 65.
But the people that are come onto the program, they're going to be able to live at whatever their income level is, all the way up to 138. Okay, what about the block grant question? We have been told in the past, I think I might have even worked with you, and we were told that the federal government, once you do a block grant, that there's a cap and you don't get to go above it.
I think Senator Silvey kind of addressed this. The administration currently is getting much more willing to work with states on creative ideas. I don't know if they would approve a growing block grant. Don't have the answer to that question. Is it a possibility? Yes. Is it a certainty? No.
So, but our current understanding is that once you do a block grant, you're locked in, right?
Well, that's how past block grants have worked. So the TANF block grant, for example, is a set dollar amount. Child development block grant is a set dollar amount. I think what the senator is proposing here, Senator Silvey is proposing, is going to CMS and saying, in order for Missouri to be willing to do this, we would want a growing block grant, one that would grow with the medical CPI or some other feature. I don't know that they would approve that.
Do you have any documentation to indicate that they might?
No, I don't have any yes or no or indifferent.
Under the expansion, the state is responsible for 50% of the administrative costs that are of the new population. Where did you put that into your spreadsheet?
It is on the bottom of the sheet, in that very bottom, row 2. So those are the estimated. Obviously, the first year is higher because we would have some information technology costs. The cost comes down in year 2 because those one-time costs are paid for.
Okay, in every other state that's expanded, the population, the newly covered population was underestimated. And it turned out to be much higher for work effect and so on. How have you counted?
We revised this model this year based on newer information. So all of our numbers have been updated. If you compare to last year, we, for example, are assuming more people will come in and need mental health services, et cetera. So we have reflected on this sheet some of the experience of other states. Do we know for sure that we're right? No, but we did try to the best of our ability, working with Mercer, to update, refresh all of our numbers based on newer experience.
Thank you. Secretary?
Yeah. To me, it seems as though if we don't get an expanding block grant, that's all bets are off. Because we're gonna have to tax the providers to make up the rules. Because we are going to have,
The way
we
I
are going to have increases.
The way I've written the bill, if they don't give us what we ask for, we don't do anything at all.
Okay.
When we say status quo.
Yeah, this would be,
Right. Because I'm not going to propose something that I believe to be financially unsustainable.
and that would,
Yes.
okay.
Any other questions, Senator Onder?
Yeah, a question about the administration. So the state is eligible for half the cost of the administration. And the figures I've seen is that they nationally about the costs of Medicaid administration are about 7%. 3.5% of $2 billion is a lot more than the $1 million you have on the administration line under E2.
Let me explain. Well, number one, the state of Missouri always does things that are less cost administratively than any other state. So we're cheaper administratively than the average. Second, some of those administrative costs under this model would be borne by the plans, the managed care plans, because the proposal is that this would not be done through fee for service. So you are basically having.
Well, right now, managed care is only pregnant kids.
Correct.
You're assuming this whole program is switching to managed care?
For all of, no. This is just the expanded population.
You're assuming the whole expanded population is going to be going to
All of
managed care?
those who are healthy, the exception would be those who are medically frail. And those who are medically frail, so like the CPS and the ADA clients, are already largely managed by Department of Mental Health using 100% GR. And those individuals will now be in the Medicaid program. Mental health will do exactly the same management they're doing today, only we'll be able to earn 50-50.
So, okay, so the mental health patients you offload onto the Obamacare Medicaid expansion, you're saying you're already paying for the administration of them right now.
Correct.
Now, of the $2 billion number you're talking about, that you're estimating that that's going to be 22 million, gradually increasing to 29 million.
No, if you look at box B,
Box B.
row 4 and 5, row 4 and 5,
B4 and 5.
those are the costs for services that would otherwise be provided through the Department of Mental Health. Most of those, at least in the first few years, are people they already know. And in future years would have been people who may have come into them anyway. So you're talking about let's go to the first full year, fiscal year 2017. In fiscal year 2017, row 4 is 325.
I'm sorry, you're on B4?
B4.
B4 is 325 million in
And
fiscal
then
year 2017.
just below that, 243 million. Those are individuals who are in need of mental health services, who would largely be already managed by the Department of Mental Health or the community mental health centers.
So of the, say, I could phrase the number $2 billion. So of the $2 billion, how much is going to be new employees?
You're talking about everybody in row 1, 2, 3, and 6. So $1.5 billion, $1.6 billion, $1.7 billion, $2.4 billion.
So $1.7 billion of the 2.4 billion. Okay. So if I multiply $1.7 billion by 3.5%, again, I don't know how much more cheaply Missouri administers our Medicaid program than other states. But if we multiply 1.7 billion by 3.5%, we get a heck of a lot more than the $800,000 that you're showing for the bottom.
Right, and that was the other thing I mentioned, Senator. Our managed care plans will be doing most of the administration, and those costs are already captured in box B. They don't have to be captured separately below. The administrative line on this sheet that shows up down below is just cost for the Department of Social Services, for example.
So,
The managed care plan costs for administration are captured in box B.
so Senator, is it in your bill that the expansion population is all going to be covered by managed care?
Senator, this bill creates the ability for a joint committee of the House and Senate to completely rewrite Medicaid, so whether or not they're on managed care would be completely up to you and I.
Okay, but the budget directors, us, the administrative line here assumes that these are all managed care and that the administration costs are going to be minimal.
Well, the social services costs are what's reflected below. As I said, the managed care plan administrative costs are captured up above in box B. If hypothetically the legislature decided through this process that they weren't using managed care, then those administrative costs that we are otherwise paying managed care plans would shift over to the Department of Social Services line. Does that make sense?
Okay, thank you.
Thank you. Thank you, Mr. Chairman. Just a couple of questions. First, process question. For either one, I guess. The process by which the state would obtain a block grant, and Senator Silvey said that we wouldn't move forward unless we maybe have it. Is that approved before we formulate what the program looks like? You know what I mean? Because you're saying there's a joint committee after the fact. Is that just a general application of allow us to have a block grant to decide what it is, or do you go in with what you want to do first?
The concept that I have is that we go in and tell them, either you give us complete flexibility or we don't do it, and not go in with a specific, this is what the committee has come up with. I suppose you can do it either way. Nothing would prohibit the committee from meeting while we're trying to negotiate for the block grant.
But you would have
It wouldn't have to be. I don't anticipate the committee meeting, developing a plan, and then taking said plan and asking for a waiver. I anticipate going and saying, either you give us the ability to rewrite this or we don't do it.
But we would be voting on expanding eligibility before.
Contingent upon the flexibility. If we don't get the flexibility, we don't expand anything.
Okay. I would imagine that they'll probably want some, I don't know, they would probably want specificity of what we want to do, violate what they view to be the, what they want the program to look like.
Well, I'm completely open to helping write a plan. I mean, I came up with a plan last year and everybody wanted a block grant, so this year I came with a block grant.
No. Well, my question is about the block grant. Is it written or is it not written ahead of time? That's basically my question. And I think what I hear you saying is that there's a general application for a block grant. It's not a defined.
Right, if we took in a proposal, it wouldn't be a block grant. It would be a waiver for the proposal.
Well, what we would do with the block grant.
Right, but it would be a specific proposal at that point. It wouldn't necessarily be a block grant. So I'm open to anything. I mean, I'm happy lining out a number of reforms that I think should be in the Medicaid system, as I did last year.
I would imagine a block grant, figuring out what the new program, as you said, from where one would look like, would probably take a fair amount of time. Yes.
Imagine it take a little while.
Okay. And the second question, I guess, I wanted for you is, in these numbers, then, it looks like, is it assumed that the newly eligible age-blind disabled are under managed care?
Under our proposal, no.
Okay, so right now they're not under existing eligibility. Expanded eligibility under this proposal, age-blind disabled is still clearly not under managed care based on.
Right, the current ADD population would stay where they are, no change in this model,
Right.
stay where they are, no change. The new medically frail population, if you come in through Medicaid expansion, or those brand new people, we are assuming they also do not be managed care.
Okay.
Senator Shaw.
Just a follow-up. On box B, lines 2 and 3, why why would we have costs under the exchange and what is no health works?
This is the governor's proposal that he has talked about. What you all would do would probably be different than this. The governor's proposal is that anybody who is above 100%, that 100 to 138, would be served through the exchange rather than through normal Medicaid. The state, through the Medicaid program, would pay the cost of those premiums. That's what this proposal is. And the No Health Works is that for small businesses, that those small businesses could provide insurance directly to their employees. And if they were Medicaid eligible, the state would help pay the premium cost.
And do we get a 90-10 match on those costs?
Yes.
So do you have anything in writing from CMS that says that that's, permissible?
Other states have done it.
Okay. Could you give us some documentation about other states?
I would do that.
Senator Onder.
Yeah, I have a follow-up question, but I think this is following up on Senator Schmidt's question, but probably more of the bill sponsor. So what has many times happened with these Medicaid expansions is that states have asked for a number of waivers. The state passes the Medicaid expansion. The headlines are state acts expands Medicaid. And down the road, waivers are denied. What you're saying is that if our block grant requests were denied, the whole bets off, no expansion happens?
Well, in most of the states that have done some sort of expansion and negotiated with CMS, the governor has gone and negotiated specific changes that they want. I think everyone understands that we are probably not of the opinion that we should give the governor a green light to go try to negotiate changes to our Medicaid program. So what I'm asking for is one waiver that mirrors the Rhode Island local waiver that they received, and say, if you want us to do this, we will do it. The legislature will figure out how to do it. And we're not coming in asking for X, Y, and Z and only getting X. We either get the flexibility or we don't.
Okay. You made a statement that, quote, last year everyone wanted waivers. Was there a vote in the House or the Senate I'm sorry, everyone wanted block grants? Was there a vote in the House or the Senate? Maybe any share?
It actually made it, the proposal that I wrote last year made it through a committee in the House and to the Rules Committee in the House. In the Senate, we had it on the board for a little while. Not last year, I'm sorry, 2 years ago.
2 years ago.
4 years ago. I took that proposal to the floor of the Senate, and perhaps when I say everyone wanted a block grant, I should be more, maybe that was a little loose with my words, but when in the inquiry that I had with Senator Lamping,
sure,
he specifically said a block grant is the way that we should go. My trepidation in that inquiry was I didn't want the governor to have the ability to completely rewrite the program without our input, and so I was not in favor of that.
Sure.
What I've come up with in the meantime is yes, I will accept the idea of asking for a block grant, but I want the legislature to control how it's used.
So Senator Lamping said something favorable about block grants. Do you know if Senator Lamping ever endorsed an Obamacare Medicaid expansion to 188% of poverty?
Well, I haven't spoken with him about this, but I will say the day that I proposed this, he said on Twitter, this is 100% the way to move forward. So without speaking for him, I'm going to look at his Twitter feed and find that.
So everyone is Senator Lamping speaking better about block grants.
Right. I mean, this whole proposal is a Republican proposal that started with Paul Ryan when he was chairman of the House Budget Committee in Washington.
How did Paul Ryan vote on the Affordable Care Act, Senator?
The whole concept of block granting Medicaid originated with Paul Ryan as the chairman of the House.
Oh, sure, no, block granting Medicaid, but Paul Ryan voted how on the Affordable Care Act?
Right, he voted the same way I have voted on straight Medicaid expansion, which is now.
Okay. Thank you.
Thank you. I'll tell you what I think we're going to do. We're going to not adjourn, we're going to recess and continue next week. That's agreeable to the presenter.
That's fine with you, Mr. Chairman.
Another thought to testify. I hope someone. Okay. Okay, we'll adjourn, we'll pick it up next week, right here. I hope I did not cover, I'm talking to anybody ready for Braille or Word, if they want to do a written testimony or something like that, it will have the same way. But if they can't come back.
So for anyone in the room who could not come back and speak to testify in person, if they would submit the testimony in writing.
I'll make sure maybe get it, because I apologize to them.
Thank you for your notice, Mr. Chairman.
All right, so, my, chief staff, so we have to adjourn, recess, so we're going to adjourn, and we'll pick up next week here. Thank
You know, yeah.